Thank you everyone for coming along this afternoon for what is an incredibly exciting event. Over the last 2 years we've been doing similar events to this for the public, but it's about time that the Health and Social Care System of Somerset had its own event. So we've got a sort of an eclectic mix of things related to metabolic health, and I'm particularly really excited to be here this afternoon because it's something I've been extremely passionate about for the last 4 to 5 years, and most of my day now revolves around getting up in the morning and focusing on something related to what we're talking about today. The reason I'm so interested in it is there is an enormous need out there for people to have support and the knowledge to improve their health. When you open your eyes and see what's going on with the healthcare systems around the world, they're absolutely collapsing. And our typical model of dealing with that, which is diagnose a inverted commas disease and then put people through a drug production line, is not helpful for everyone. What is helpful is probably collecting together the people in this room, the people speaking, the population across Somerset, and actually starting to really address the root causes of what's happening and turn around the epidemic we're seeing. And the nice thing is, and if some of you may not have been exposed to all the information you'll see through this afternoon, the nice thing is suddenly there is an enormous amount of hope you can have. The sense that actually the difference we can make is far outstrips anything else I know, certainly in medicine, and where if you wish to get involved with this sort of thing, when you use a unit of energy, the outcomes you will see for that are just incredible. So just very briefly, to put it all in a bit of context, and just, I guess, my background as a GP, I'm Health and Wellbeing Lead for the CCG. I'm also Chief Medical Officer for diabetes.co.uk. Somerset, 7 to 8% of the adult population got type 2 diabetes. 2/3 of the adult population in the UK are overweight or obese. 1/3 of the UK population have got pre-diabetes. That in itself is costing Somerset at least £150 million a year, if not more. Poor metabolic health is driven mainly by lifestyle factors, including what we eat, our physical activity levels, sleep levels, amounts of chronic stress, and obviously there's a genetic component. And there are an enormous number of things related to it. So if you just reflect on these as they're read out and think about the people you see in your day-to-day work, what percentage of people does this make up? So we've got type 2 diabetes, pre-diabetes, obesity, heart disease, stroke, non-alcoholic fatty liver disease, gout, some cancers, dementia, some inflammatory processes, polycystic ovarian syndrome, thrombosis, kidney disease, depression and anxiety. Certainly as a GP, this is what creates the need as we walk through the door, and our model for meeting this, our traditional 10-minute appointment model with a drug at the end is providing people, I think, with a disservice, but it's so easy to do something better.
Thanks. Hello everyone, my name is Tara and I am a practicing dietitian. My background is diabetes, obesity, bariatric surgery, and today I'm going to talk very, very briefly, I only have 10 minutes, about food and metabolic health. But I guess the first thing that I think everybody in this room can agree on, here we are, is the confusion around diet at the moment. So every single day I have patients coming to clinic, and I'm sure all of you do as well, and I'm sure you are confused yourselves about diet at the moment. So why are we confused, and why are our patients coming to us confused? This is 32 different headlines. Chocolate beats diabetes, pills beat diabetes, vaccines beat diabetes. It's so difficult, and I never ever judge a patient for coming to clinic and just saying, look, I'm completely fed up, I don't know what to do, I keep hearing different things. And what I think is most important for us as healthcare professionals is that we need to be pushing the same message. It's really, really difficult when you get a patient coming to clinic and they say, well, this person told me this, my doctor told me this. And I think that what we really need to do as a whole is just to get back to basics. I really do think that. I'm not going to bore you all with this. We all know about macronutrients. We know about protein, we know that they're essential in the diet. Our body can't make amino acids, or some of the amino acids ourselves. We know about fats. Fats are completely essential to our body. We have this idea that fats are a bad thing, and this low-fat message has been pushed for such a long time. Yes, these types of fats, absolutely. Trans fats, fats in refined foods absolutely have no place for our diet, but I would absolutely argue with anybody who says that we don't have place in our lives for healthy fats. And when we think about metabolic syndrome, the one thing we obviously need to think about is carbohydrates. Can I ask anybody in this room if they know what the minimum amount of carbohydrates that our body needs every day is? Does anybody have any ideas? Zero. Yes, that was a trick question. So we do not have any direct physiological requirement for carbohydrates in our diet. Our body can make all the glucose that it needs itself. That is not to say that carbohydrates can't be used as an energy source for some people, but we really, really need to think about metabolic health, insulin resistance, type 2 diabetes, pre-diabetes, and how quality and quantity of carbohydrates are so, so important. When we think about sugars, we think about simple sugars that are broken down. Everybody in this room knows, and I think the public even know where sugars come from. So they come from our sweet foods, they come from takeaways and the things that we should be avoiding. But what about starch? So we have this some guidance that the general population, the healthy adult, should be having their meals based on starch. But do we know what starch actually is? And do we know what the building blocks of starch actually are? Does anybody know? Don't answer. Anyone else? Yes, absolutely. We know that starch comes through digestion and are broken down to glucose. And I think we really need to remember that. So when we think about calories and our macronutrients, are they all equal? I would argue no. If we have patients who are insulin resistant and a population who are pre-diabetic and type 2 diabetic, if we are recommending diets extremely high in sugars, whether that's from obvious sugars, free sugars, or it's from carbohydrate, we are going to see a blood glucose response. Protein, we can see for some people has a glucose response, and my best friend fat down there, the healthy fats, generally we don't see much of a response, and we need to remember that for our metabolically unhealthy patients. I'm not going to run through all of this, but we need to think about free sugars in our diet and then ultra-processed foods. So this is a very long slide, so I won't go through all of this, but I do want to highlight some things about free sugars. I often have patients come to me and say, I've cut out all the sugar, I'm baking cakes, I'm using honey instead, things like that. So sugars which are naturally present in foods also count towards free sugars. I'm not sure if anyone's familiar with Dr. Zoe Harcum, but she always says that when people ask about what is real food, so I say fish swim in the sea, but fish fingers don't. Butter comes from cows, margarines that are hydrogenated don't. So it really is very simple. This is NDNS data from 2015-2016. And just very briefly to point out, the free sugars intake is recommended to be within less than 5%. And here we can see that it's double for all adults and children, if not more. But what I really think is really interesting, and maybe I'll ask another question, in 1.5-year-olds to 10-year-olds, where do we think that the most free sugars from our children's diets are coming from? Does anyone have any ideas? Sorry? Say again? Drinks, close, very close, but not the number one. Cereals and cereal products, absolutely. Followed by juices. So this is really something we need to remember. Telling our children to eat the healthy breakfast cereals, this is contributing towards most of the ultra-processed free sugars in our children's diet. For adults, so 19 to 64-year-olds, any ideas? Same question? Yes, so confectionery is the number one component of free sugars in our diet at 25%. Cereal and cereal products follow very, very closely at 24%. So essentially we're getting the same amount of free sugars in our diet from cereal and cereal products than we are from confectionery. So I think we really need to remember that. Just more information, another study published in the BMJ just earlier this month, so showing starchy foods, breakfast cereals, drinks, sugary products to be a massive component of ultra-processed foods in our diet. So when we think about carbohydrates, we have to think about the glycemic index. I'm not the biggest fan of the GI index myself, but I do think it is important to note that every patient is different and everybody's going to have a different response from carbohydrates. So it's a ranking on how a carbohydrate will affect the blood glucose level of an individual. So lower GI, meaning that it digests slower and doesn't have as much of a blood glucose response, but of course the GI does not take into account the portion sizes of food. So often you'll see documentation saying, oh, well, pasta is a low GI food. I challenge anyone in this room or any person in this country to have a huge bowl of pasta and then check their blood glucose levels. And if you are insulin resistant, type 2 or pre-diabetic, you're going to have a huge response to that. So here are some healthy foods, or so-called healthy foods: dates, watermelons, rice, bran flakes, all extremely high in GI. The glycemic load is something we need to take into account. So we can choose from the lower GI foods, but we also need to take into account the amount of carbohydrate within that food. So just as one very brief example, often patients will come to clinic and say, Tara, I'm doing great. I've switched over to all the brown things. I'm eating whole grains. I'm having brown pasta. So we'll say, okay, let's look on the scale. Yes, it's a low to medium GI food, but it's a very high glycemic load. And if any of our patients have glucometers, I would always ask them to check when they eat these types of foods to see their response. And generally, by the next time they come back to me, the pasta is gone. This is just one very brief example, I know I haven't got much time, of an extremely, extremely distressed 32-year-old lady who came to me in clinic. Metabolic syndrome, type 2 diabetic, and this was an example of her blood glucose levels. So her Diasend download, 17, 20 plus average a day. I only had about 5 minutes with her in clinic, and she just said, please, just tell me what to do. I'll do anything at this stage, just tell me what to do. I simply said, just eat real food. Please just go and eat real food, and then just come back to me in 4 weeks and we'll have a proper discussion about how we go on further. So that's all I said, eat real food. She comes back 4 weeks later, and this was over Christmas, can I say? Her blood glucose levels averaging 6, 7. I said, what have you done? And she said, I just stopped eating foods from packets. That's all I've done. And since then, this was in January, since then she hasn't really done very much else apart from eats real food, looks at her carbohydrate portions, still has the occasional treat, but has got so much energy, she's now signed up to do a half marathon. So this is a lady who came in completely distressed, my life is over, and 3 really, really simple words brought her from that to that. I have to finish up now, but my overall message for us is to, especially healthcare professionals, I think it's really important that we educate ourselves first, and then we educate our patients. So we have to give them that choice. We cannot have them coming into clinic and just giving them more drugs without giving them a choice to look at their diet. If any of you are GPs, you'll see that there's many GPs across the country who are saving so much money in deprescribing diabetic drugs. Avoiding highly processed foods is really basic stuff, this is. What I like to do is focus heavily on the foods that my patients should enjoy and can enjoy. Reconsidering low-fat products, so making sure if we're having low-fat products to watch that they haven't been lots of extra sugars added. If a patient wants to have carbohydrates, making sure they have the low carbohydrates. And I think support and encouragement from healthcare professionals is so, so important, and especially GPs and doctors in the room. Patients really, really, in my opinion, love to get some good feedback from you. And this lady with these blood glucose levels came in, and the first thing she said is, where's the consultant? I want to show them something. So I thought, okay, well, never mind what I said, we'll go tell the consultant. But they really, really do like to see their healthcare professionals taking some interest in their own health. And I think, last thing, just some resources for everyone. Everybody here has, we're all stretched. 10-minute appointments is not enough time to go through somebody's diet, but you can certainly, there's lots of resources out there for patients. I can see on these tables here, you've got some lovely resources for exercise, and anybody who doesn't work in this area, I always use students or work experience people. Really, really good to get them in, get them to look around the local areas, cookery classes, anything else that you can think that will help people with their diets. And I think that's it.
Brilliant, thank you, Tara.
My name's Catherine. I'm a practice nurse at Preston Grove Surgery in Yeovil. I've been specialised in diabetes for the past 11 years. I've been a practice nurse for 14 years. So this is about my journey, really. My patient care is patient-focused, person-focused, and I do have an individualised approach. And I do take into account each person as a whole. But previous to last January, I used to get the patient in to try and hammer down the HbA1c, get it as low as I could without too much emphasis on weight. Before a consultation, I'd get the patient, before they came in, I'd look at their HbA1c result and check whether I could titrate their medications up or see what medications I could put them on. Rarely did I stop any drugs. They just went on more and more. I used to joke that I could have been the next sales rep for each new drug on the market. Quite embarrassing, really. I didn't think I was doing anything wrong because, as we all thought, diabetes is a progressive disease and just gets worse and worse. And what hope is there? They just end up on more drugs. I was wrong. I realise that now. We now know that diabetes is no longer a progressive disease and that there is hope, and diabetes can be put into remission. Last January, something remarkable happened, and it's not only changed my life, but it's changed a lot of my patients' lives too. A patient bought me Michael Mosley's 8-week blood sugar diet book. He came in and I said, "Wow, what have you been doing?" And he told me. He went immediately to Tesco's, came back with the book for me, went home, and literally the penny dropped. No longer was I going to be doing what I was doing and what I was practicing. Before the book, my dietary advice would be eat less, move more. 4 words that now slightly make me cringe because I just know it doesn't really work. So from then on, after the book, I altered my whole approach, which meant that I was not only giving dietary advice, but I was talking to patients about sleep, movement, and stress. And we know if people are not getting enough sleep and if they're stressed, they don't make very good food choices, and it can elevate their blood sugar levels. So all aspects of my care had changed. I was given definitely individualised, person-centred care. And I was practicing lifestyle medicine. I'd never heard of it before, but I'm proud to say that's now what I do. So I've been on this huge learning curve and absolutely loving it. Never before have I had so much enthusiasm for my job and just totally and utterly motivated. I went to work the very next day after the book, so excited to share this new advice with patients. So I was on a learning curve and so were the patients. I started talking to patients about eating a low-carb diet, which essentially means eating real food, cutting out the processed foods, cutting out the sugars, including the healthy fats such as nuts, seeds, and eggs. My take-home message to patients is if you can pick it off a tree, pull it off a bush, it's been running around the field a couple of weeks before, then it's real food, and they just seem to get it, or try and eat like your great-great-grannies would have eaten. I encourage cooking from scratch as much as they're able to, and I realise that some patients do find this difficult, but I try and coach them as much as I can and give lots of support. And I do come up with simple recipes for them, and I've got lots of books in my room, and I do signpost them to lots of different online support. I do understand that this way of eating isn't for everyone, and sometimes it's just not appropriate. Sometimes patients can just make simple changes, and that's enough to improve their metabolic health and their well-being as well. Sometimes just giving up cakes and biscuits is enough, swapping breakfast cereals for eggs, or some people give up bread and they're just amazed by the difference that can make. This is so motivating for patients, and it just keeps them on the right path to keep going and just spurs them on. Lots of patients say to me they've never felt better, and they just can't believe how well they feel. They don't feel bloated anymore. They're clearer in their heads. It's just phenomenal, actually. What I have learned is that patients can't make the patients can't make choices until they're ready to and they're in their right headspace. How many times have we heard people saying, I expect probably a lot of us in the room might have said it, I'll start Monday. I'm just not in the right frame of mind at the moment, and all I want to do is eat. So we know that you have definitely got to be in the right headspace to know when you're ready. And I just let patients know that I'm there, going to support them in whatever changes they can make, whether it's big or small. We've got a really, really great team at Preston Grove. We've got a really good team of health coaches who are sat at the back. And they support our patients in every aspect of their life. They give lots of support in lots of different areas. They run a weekly walking group, which has gone from strength to strength, and a monthly friendship group. We've also set up a diabetes and pre-diabetes peer support group, which is going really, really well, and that's open to all of Yeovil. So what results have I been having? A lot. I'm so proud of my patients. We know that from the direct trial that if patients lose weight quickly and if they can achieve a 15 kilogram weight loss or any weight loss, they can put their type 2 diabetes into remission, which hugely benefits their metabolic health. If patients lose weight, they can improve lots of health areas. I'm amazed by how much weight patients lose. And once they're given the lifestyle advice and support, it's just never ending. No matter how much they lose, though, there is always a reduction in their HbA1c. I've got 8 patients that have reversed their pre-diabetes, and I've been doing this since, last January, but really started seeing results probably from about March. I've got 7 patients that have put their type 2 diabetes into remission without medication, and many, many other patients that have improved. Lots of patients with pre-diabetes that have not then gone on into the diabetic range, which is just brilliant and so motivating. I've seen many areas improve, such as non-alcoholic fatty liver disease, gastric problems, bowel problems, depression, loads. Patients are just so much happier in their self as well. And you know what it's like, if you lose weight, you can get your new dress on and you just feel so much better. And they do come in bounding with enthusiasm. I've been able to prescribe medications too, which is really motivating. Some patients have been able to stop insulin, or some patients have been able to massively reduce their doses. And I initiate insulin, so it's been really nice to say to patients that I've initiated, do you fancy getting off that insulin? I've got some advice that we may be able to help you to get off the insulin. So it's really encouraging to say to a patient at diagnosis now, would you rather try some really good dietary and lifestyle intervention or go on a tablet? And I've yet to see a patient that would want to go on a tablet. One patient had pre-diabetes. He pitched up to my room with type 2 diabetes with his HbA1c of 120, and within 6 months of going low carb, healthy fats, his HbA1c went down to 38, and he lost 4 stone, and so did his wife. So he put his type 2 diabetes into remission. Really, really amazing. Just so proud of him. So with all these changes does come a lot of time, support, effort, and obviously ultimately cost. So if the NHS want us to save money, then we need more money to fund us in primary care to enable us to help stop this rising epidemic of type 2 diabetes and obesity. We need to give our patients hope, and we owe it to them as healthcare professionals. My passion is helping patients improve their health and getting to the root cause. It's something that I absolutely love, and I just want to give my best to every patient and just strive to get brilliant results for them. Thank you for listening.
So as Campbell said, I'm Peter, GP. The WSI means with special interest in sport and exercise medicine. So who am I? I'm a GP in Poland medical practice, so I work between Eddington and Woollavington, just near Bridgewater. I also work in Musgrove A&E, and I'm a student of sports medicine in Bath doing a study in sports medicine. And I also work with diabetes.co.uk as one of their medical advisors. So I'm on the front line, GP at the coalface, just like Catherine is as well, really, and many people here today in the front line trying to combat this epidemic of lifestyle-related factors. Metabolic disease you've heard of today, so it encompasses lots of different things, and we'll try and give you a definition for that so we all feel a bit more comfortable with what we're talking about. So that's where the firefighting that I do happens, just in Woollavington and Eddington, but there's fires in Bridgewater all over the Western world, unfortunately. So looking at metabolic syndrome, and I thought it would be useful to define what actually we mean by that. The International Diabetes Federation 2006 said that you have to have central obesity or a BMI over 30 and 2 out of the following. So raised triglycerides, high blood pressure, type 2 diabetes or pre-diabetes, and a reduced HDL or a protective cholesterol. So what is the scale of the problem, and every pun intended? Looking at the global issue of lifestyle-related factors is just staggering. Any Western country you go to, you're going to see obesity, you're going to see these issues. The concern that we have really as a GP, to go back slightly, is the fact that this creates a false sense of security, or what I call a false wellness. So all these can go on under the radar for years and years and years before anyone's aware. So basically, there's a huge problem globally. If you've got metabolic syndrome, it's about a quarter of the world's adult population. So a quarter of this room. It's quite scary. You're 2 times increased risk of having a heart attack or stroke, 5 times higher risk of having type 2 diabetes. The global incidence of diabetes is going to rise. It's going to double by 2025 with an enormous, obvious burden on healthcare costs. To open up to the group, in 2003, the direct healthcare on EU countries was $65 billion. What do we think the predicted cost is going to be in 2025? Any ideas? 100? Any more? 600. 340. So nearly 400. So that's quite scary. So bringing it back, so that's global. Let's bring it a bit to the UK. We are champions at ultra-processed food. We're doing really, really well at eating this kind of stuff. We're the worst country in the EU at this ultra-processed, so food that's packaged, highly, highly refined, lots far removed from when it comes in its most natural form. Just to highlight, the Mediterranean countries are really, really good at this. But my own Ireland, obviously, just equally as bad, but just not quite in the red. We're not alone. So this is England. This is every country in the Western world really has rising rates of obesity from about 1970, 1980 when the USA started. We were a bit behind, but we're all following a trend. And then bring it even closer to home. So this is England's obesity hotspots. And we're doing really well down here. The darker we are, the worse we are. So unfortunately, despite, well, we're actually the worst in the Southwest. So it just shows that, we're not doing very well down here. About 70% of men being obese and over 50% of women. By 2020, 8 out of 10 men are going to be obese and 7 out of 10 women are going to be obese. Staggering. We worry about obesity for many reasons. Obviously, we have our own worries about you want to look well, you want to have clothes fit you, you want to be healthy. But on a microvascular level, and the real damage is coming from these macrophages around adipose tissue. So these little cells around fat cells, they excite these boys here. Very, very, very bad. Resulting in liver disease, and we have a liver specialist here, so obviously hopefully she will be looking at a bit more. So this really is bad news. Just by being obese, you're exciting all of this badness, which results in this endothelial dysfunction and microvascular disease, which is really quite scary. We obviously know then obesity, this is quite a big market from a big targeting campaign from the Cancer Research UK, again looking at the fat cells, inflammation, and we're learning so much about this all the time, but the more we're finding out, the more scary obesity really is. We know about obesity and we know about what it is to be healthy, but generally the Joe Public says, well, eat less, move more. But when we're looking at the proportion of disease globally, inactivity is down here, smoking is down here, but diet is a huge factor. So yes, I'm a GP, yes, I believe in exercise, I believe in the whole lifestyle, and we've heard from Catherine and other people today the importance of a balanced lifestyle. 10 minutes isn't enough to go through all of those in particular, so I'm going to focus heavily on diet because I feel that's where I can get the most bang for my buck in 10 minutes as a GP. The elephant in the room is often something we call insulin resistance, which we're learning more and more about. Is everyone familiar with insulin resistance? Getting a couple of nods. So basically it's the tip of the iceberg here is the gout, blood pressure, bad lipids, cholesterol, arterial disease, but right under here you have this huge iceberg basically. On the right here you've got people who are very lucky, they're carbohydrate tolerant. They're athletes, people who can eat whatever they want, they're stick thin, and often they can do very well. They don't need to be in a low carb diet, they do just fine as they are. For the majority of us, or by the 70% of us or so who are overweight and obese, often are intolerant to carbohydrates. And we've got something called insulin resistance, resulting in high waistline, obesity, metabolic syndrome, type 2 diabetes, things we're going to hear about all day today. So it's all encapsulated. The guidelines from the International Diabetes Federation look at a moderate calorie restriction, increase in PA, which is physical activity, change in dietary composition, and to treat the individual components of the syndrome. So just to remind ourselves what they are, so you've got obesity, then you've got your type 2 diabetes, blood pressure, and cholesterol. So we'd think about statins, tablets, rather than looking at the obesity. Looking at NICE guidelines for diabetes, they encourage a high fiber, low glycemic index sources of carbohydrate in the diet. So looking at my own patients, this chap you can see his weight gain from 2003 to 2015-16. So you can see here, steady, big weight drop and then a significant weight gain. Another patient, a bit of a weight gain here, which coincides with type 2 diabetes, or pre-diabetes in this case. Another chap, slight increase in weight, increase in his diabetes level, so worsening control. Another lady, lots of these. I'll try and explain what these dips in weight could signify. Diabetes, weight, diabetes. This is metabolic syndrome. This is a patient of mine called Donna. She's allowed me to use this today, and she has had metabolic syndrome. This is what the reality we're facing with. We walk in Taunton High Street, you walk in Oxford Street, you walk down any street in England, you're going to see Donna. Weight, diabetes. So, carry on. I'm conscious of the time. So as a GP, 3 years ago, I'd say what you need to do is eat less and move more. And if you can't do that, we'll give you medication, we'll give you statins, give you blood pressure tablets, we'll give you diabetes tablets, and hopefully we'll get your numbers right. As Cass was saying, we'll get the numbers right, because we can't do much about this. We say to eat. Have you heard about the Eat Well guide? So it's designed to be healthy, and that can often, for some people with metabolic syndrome, lead to this glucose spike and a resulting dip in your insulin. We also say to move more, and people think that means joining a gym. But we're living in a world of convenience. Thankfully, we don't have any gyms with escalators here, but I dare say if we did in Taunton, they'd be used more than the stairs. When we look about Eat Well, Move More, there's a very interesting study done in America in JAM in 2006. They looked at people following a normal diet and people following an Eat Less, Move More approach, and they found that at 9 years, it was just the same. So it's easy to kind of keep the Eat Less, Move More for a while, and people can often relate to that. I know I can when I tried to do it myself in the past. Very hard to do after a certain period of time. Has anybody watched The Biggest Loser USA? Brilliant TV. So is everyone familiar with what the concept is? A couple of us knows there. So what they do is they get really, really big people, like morbidly obese people, get them into a fat camp. They get some TV presenters, get some motivational speakers, put these people through hell basically for good TV. Some of them lose weight, some of them don't. They did a study, this was from 2009, and they looked at where these people are in a couple of years' time. The Biggest Loser has had 9 seasons. Do you know how many reunions they've had? How many reunion episodes? 0. These people don't tend to do well over long periods of time. Every patient that started the study started up here, and they all lost weight. Okay, they did the Eat Less, Move More. However, their basic metabolic rate dropped as well. Okay. With the weight loss group, everyone's weight regained. Can everyone see that? Apart from a couple who've had, they had gastric banding surgery. Looking at the metabolism rates, not only did most people's metabolic rates slow, despite the weight gain, for many, it continued to slow down. Exercise is very important. We know that for many, many reasons. For metabolic syndrome, it's no different. This looks at high intensity interval exercise. This is steady state exercise. This is no exercise. So there's a clear correlation that the high intensity or HIIT exercise is probably better than steady state for people who want to improve metabolic syndrome. I don't want anyone to think, go away from today, that you don't need to exercise, because you definitely do, but I just can't focus on both for now. So eat less, do more. So we all have our basic metabolic rate, which is going to our energy intake. If we cut our energy intake, we'll cut our metabolic rate. Otherwise, we'll just die. If we use more energy than we're taking in, we just die. Anybody who's done an eat less, move more severe calorie restriction diet will say it's very hard to stick to, because you've got to your goal weight, you've got to your wedding, you've done whatever it is, or it's just too hard. And you often go back to the old way of eating. Unfortunately, the basic metabolic rate doesn't get the memo and stays at the same. So you're then left with often an energy surplus. So when we talk about patients, we look at the food that we're telling people to eat. This is a standard breakfast, which is often said to be healthy, and would be accepted if you were to ask a child on the street or most adults what a healthy breakfast would be. It's got cornflakes, milk, brown toast, and pure apple juice. Would anybody want to hazard a guess how many teaspoons of sugar would be in that? 21. Okay. You compare that to a breakfast which has got low carbohydrate, eggs, mushrooms, cheese, tomato, coffee with some milk. Anyone hazard a guess? Less than 1. Do you see where the problem could be? We look at fruit, but fruit's healthy. Okay, so yes, some fruit can be healthy, but if you've got metabolic syndrome, you want to reduce some of your sugar levels. You've got bananas, grapes, apples. I try and focus on stone fruits, strawberries, and fresh berries. Bread's the same. What about bread? Well, kind of, are some bread better than others? Well, they all kind of going to rise your blood sugars in a certain way. And of course, breakfast cereals, Cocoa Pops, cornflakes, mini wheat, shredded wheat, oat porridge. Nearly every diabetic I know says, I'm having porridge for breakfast, maybe with a banana. So we can see that often it can be, it's very healthy for some people. Oats can be very healthy for people, but if you have an issue with your sugar content of food, you can see there could be a problem with what you're having every day. So, how do I do what I do? So, 15 minutes, I'm very lucky in my surgery, 15 minutes. So by the time someone comes into the surgery, sits down, takes a coat off, you're looking at the clock's ticking in about 12 minutes. So I always ask patients for lifestyle. Is it okay to talk about your lifestyle? Is that something you want to talk about today? Because there's no point in me saying what I think they should do, because it's not going to happen. Ask permission. I know you mentioned goals were important to you, but often they can be for others, and we try to identify how am I going to help somebody unlock themselves? What is it that I can do to help them be the best version of them, just like Carson did for you? I find goal setting to be helpful, both long-term and short-term. I try and educate people on what healthy food is, what GI food is, involve them in their decision-making, support them, and signpost them to further resources. I always leave patients home with a real food list. So eat some of these, eat less of these, try and eat very little of these. It's quite simple. I try to use SMART goals. Is everyone familiar with what SMART goal concept is? Fine. Everyone happy with what SWOT analysis is? Fine. I find the SWOT analysis particularly useful. So that's the patient's strengths, weaknesses, opportunities, and threats. I prefer to spend more time on the SWOT because that helps visualization about barriers and how we're going to overcome them together. I like to use solution-focused therapy. So if I ask a patient, how far are you on your journey to being better? They'll say, well, I'm a 3. I say, well, what's going to make you a 4? What are you going to feel like at a 4? What are your family going to make you feel like? How's it going to be? I often write down a signed agreement. So you want to come back in 6 weeks. You want to lose a stone. You want to be healthier. I'll get them to write it down. I'll sign it and they'll sign it and then they'll take it home with them. It's a real privilege to be a GP, to go on the journey with patients. We're all on our own journeys, which brought us here today, and we'll see each other again sometimes, maybe not. But the beauty of being a GP or a health coach or any healthcare worker is it's an enormous privilege to be on the journey with them. And it's a real honor to be able to help people improve their metabolic health. It has to be personalized, it has to be individualized to that person. I totally agree with what's been said before. Low carb isn't for everybody. In fact, it can be dangerous for some people. So we have to be very careful what we do. It's certainly not a blanket advice for everybody, but certainly those who find it's helpful, don't look back. I like to make it very simple for patients, because if you say eat less, move more, it's not very tangible. It's kind of, yeah, well, I know that. Eat healthily, I know that. I look at the 84 rule. Does anyone know what the 84 rule is? So I say to patients, how many meals a day do you have? I have 3. So, well, then you have 84 meals a month. I'm like, okay, I have 84 meals a month. And then say, do you think you could improve maybe 60 of those meals in the month, in the first 6 weeks? And I'll say, actually, I probably could do that. I could, and then we start the ball rolling, rather than saying, you just need to do this. Is there a way in which we can do things better and make it simpler for them? I like to use imagery. So living where we do, I'm working where I do, lots of lorry drivers from Morrison's. Other supermarkets also exist, but Morrison's seems to be a big depot where I am. And I say, listen, it's kind of like from a metabolic point of view, your engine is just on overdrive all the time. If we can improve the food you're taking in, if we can get a bit better look at your sleep, reduce your stress, you're going to bring that speeder right down again. You're going to be living the way you're supposed to live. You're not going to be carrying 50 kilograms. Your body isn't designed to carry that. So you're going to feel better on a daily basis. I also say to patients, well, if you go to Bristol Zoo and you see monkeys in a display, what are they going to be eating? Are they going to be having McDonald's? No, okay. Are they going to be having soft drinks? No, okay, fine. So it's making it simple. What is normal for our habit? Yes, you can have grains and potatoes and bread and rice, that's fine, but if you've got metabolic syndrome and if you have an issue with sugar, it's probably going to be harmful for you. I like to use imagery, so when we talk about diet and exercise, I say let's focus on nutrition for now, get the exercise further. It's very hard for patients to make a huge lifestyle change in one day. I've got to exercise and eat healthier, it's going to be really hard. I say, okay, well let's just stick to nutrition for now and we'll focus on exercise later. And time again, patients come back and say, actually, I'm walking a bit more, or I've started running again, and they begin to get this more energy. So I try and focus on food. You've got 84 choices to eat food in a month, which can improve or impact your health negatively. So for somebody with diabetes, so we've covered this already with Tara. So this is what we're often, so when patients say, I don't understand that I eat healthy, I don't eat very much fat, and I'm doing what I'm supposed to do, and I'm having bread, and I'm having what I'm supposed to be having. As Tara already said, starch breaks down the glucose. So for someone with diabetes, that's basically what it is once you measure their blood sugar levels. So this is the standard kind of approach, have grains at the bottom and then build up to the top. I say actually that's the normal diet. It's kind of came about for the last 50 years. Can we just cut that out and make it into a square, focus on on properly raised meats, on low GI fruits and veg, plenty of eggs, healthy fats. And that's basically it, really. We make a list and we give it home to them, and they can then take it from there. Obviously, when it comes to fats, it's important to make a statement of not trans fats, obviously, as Tara said. So your Greg's pasties, your McDonald's, your Burger Kings. Better to focus on your unsaturated. Try and limit your processed meats where you can. So it's time for a bit of audience participation. How many carbohydrates on the plate? And is it equal? So when we say about a low carbohydrate diet, people often are a bit concerned, but actually there's quite a lot of carbohydrate there compared to one of those. And I know if I'm going to barbecue, I'll have at least 4 of those and 2 burgers. I wouldn't think about it. I wouldn't have 4 plates of that. There's no way I would. 20 grams of carbohydrates there compared to 1 potato, bit of spaghetti, a bit of rice. So rather than being a dramatic, dangerous diet which is unsafe and unhealthy, this is lots of colour, lots of healthy fat, and it's going to do much better to our bodies than this is. So on to the patients. First patient, 14 kilograms, 2 stone loss, off of medication, off his allopurinol, and more importantly for him, he's off his Viagra. Patient 2, he had an increase in weight. He's lost 24 kilograms, 3 stone, off blood pressure medications, and also diabetes, type 2 diabetes is into remission. Patient 3, this is a good indication, and this is a good example for me when I show patients that this is a lifestyle change for life, really. If you go back on the way you used to go, it's going to come back up again. It's not a quick fix, it has to be a lifestyle change. Despite that, it has total 12 kilogram weight loss. diabetes into remission initially, and it shows it creeps back up. So it's a good lesson that this is a lifestyle change which has to be happen forever, or else it will come back. Again, more weight loss, similar stories to before. Pre-diabetes into remission. None of these patients have joined gyms. Okay, this is all through food, all through real food. 15.5 kilograms, and just in 18 months, diabetes normal range. Okay, 23 kilogram weight loss. This is diabetes, so this is quite a good point actually. So this chap has been on his own journey, 2005, I can't take credit for that. Steady weight loss, but in the last wee while, significant drop. So 128 to about 17. His diabetes is now into remission. Was on 4 tablets here. He's on metformin here. So serious deprescribing, helping him on his journey of metabolic health, helping the local NHS budget, 1 patient, but all we need is more and more and more and more and more. This is probably my proudest moment so far. So this gentleman came to me with type 2 diabetes, new diagnosis, totally shattered. What does it mean? I don't know what it's going to be. HbA1c 133 in March of last year. It's now 51. He's on metformin. He's still having porridge for breakfast, so it could get a bit better. But it just shows what we can do. There's no medication to do this. They don't exist. So this is what he's doing. I'm just empowering him, I'm unlocking him, and it's not me being anything special. I don't have the answers, but certainly this approach is very, very powerful. And finally, it's the last patient. So, obvious improvement in diabetes, only on metformin, again, off 3 medications. LDL cholesterol, so one of your dangerous cholesterols, slightly risen, but no real increased risk. Triglycerides, significant drop. HDL, so all the factors of metabolic syndrome improving. That was done 18 months ago. That's done and now. She has done 2 half marathons, the last which was accompanied by her granddaughter as a prize. This fills us with lots of pride because the hope that we're giving her, that she's given her family, her granddaughter, her granddaughter's friends, this is empowering women, it's empowering her, it's giving this girl hope that actually I can exercise. You don't have to be a man to exercise, you can do this as a woman. And she's a fabulous advocate for what we're doing. The real message I try to say to people is eat real food. Call it low carb, high fat, call it low carb, call it just eat real food, call it what you like. It's a powerful message and the ripples are moving around. I thought I'd finish with this. So the complications of diabetes are caused by high blood sugar. Yes. What foods cause high blood sugar? Carbohydrate. What should I eat? Carbohydrate. So we're in a bit of a pickle at the moment, but hopefully we can make things better. So just to wrap things up, I'm sure I've overrun out of time. We've got a lifestyle epidemic. I try and identify goals with patients. I try and get the intrinsic motivation factors for them. There's no point in me putting my extrinsic factors on them. You've got to be healthier. You've got to improve blood pressure. It's all about what comes from within. One person's goal is going to be separate from someone else's. One person's low carb or something else's low carb. What are their motivators? What makes them sparkle? What gives them their mojo back? Signpost to resources, educate, involve and support. Not just as a GP, but as all the healthcare professionals we have here today. And a clear focus on real unprocessed food. Thank you very much.
A little bit of a specialist subject, type 1 diabetes, isn't it? I think quite a few of you here are GPs and practice staff, I think, so you will be coming into contact with type 1s at some point. I'm a GP. I'm also a medical advisor for diabetes.co.uk, and we're just about to launch a program for type 1s to help them to have the option at least of low carbohydrate stroke ketogenic type of diet. So why are we talking about type 1 diabetes in respect to metabolic health? Well, I'm going to try to show you that I think that metabolic disease is just as important in type 1 diabetes as type 2 diabetes, even though type 1 diabetes, you could argue, is just a straightforward hormone replacement therapy. So we've all had the nightmare of being rung up on a Friday evening and the patients ringing you up because they can't get hold of the community diabetes nurse or their team, and their blood sugar's 22 and they're feeling a bit sick and they're at the airport and they're about to travel through travel through 5 time zones, and what should I do, doctor? And it's Friday night, and it's a bank holiday, and you're my doctor, so I need some advice, please. And when they're not doing that, they're always going hypo, ending up in hospital. And when they're not hypo, they're always going into DKA. And when they're not going into diabetic ketoacidosis, when they're not going into that, they're swinging around with sugar control all over the place. And in fact, only 3% of our type 1 diabetics, of which I'm one, are achieving the target guideline of 48 millimoles per mole, which is way above the guideline for people who don't have diabetes, which is 42. So yeah, it's a difficult situation all round, really, isn't it? And then they get sent on to Daphne courses to learn how to eat bread and cakes and how to monitor their carbohydrate counting based around that. And so they're much more confident in injecting much more insulin, and the insulin helps them to put on weight, and they put on more weight, and they get more swings of blood sugar. And then what happens is that they start to get complications, they get amputations, blindness, strokes, heart attacks, kidney failure. Exactly the same conditions that type 2 diabetics get. So I think it's no accident that type 1s end up, even though they start off with a different disease, that they finish off with pretty well the same disease. And I'll try to show you why. Okay, so all I'm trying to show is that if most people have heard of insulin resistance. Yep. Everybody heard of insulin? Basically, insulin resistance is when you inject more and more insulin to get the same effect. So for some reason, our bodies become resistant to insulin, and that's part of the metabolic syndrome. So if you eat a load of carbs, eventually those carbs have nowhere to go, and the liver gets fatty, and et cetera, et cetera. So if you think about type 1 diabetes as a hormone replacement therapy, which is essentially all it is in type 1s, because essentially type 1s, aren't they, they just lost their pancreatic function due to whatever process, so you have to inject insulin, and that's it. But the only problem is that insulin is a highly complex hormone which has many interactions, and it's difficult to balance the insulin with the carbohydrates. So if you just look at all I want you to do is to look at that one and that one. So this is a study where they looked at, I think it was about 20 people, no, it's less than that, 14 people with diabetes. They're all relatively young. Most of them have had diabetes for an average of 12 years. And their HbA1c was about 7.5%, which is not bad, really. And they're all youngish, 20s, 30s. And they compared those with people who had no diabetes, and they put them all to sleep and did measurements on them through a cannula. So the people with diabetes are the black dots, and the people without diabetes are the white dots. Now, the glucose level here is the diabetic control throughout the night. So it starts at about 2300 hours and goes on to, God knows what, goes on to 6:30 in the morning. So you can see that in a person with type 1 diabetes, their glucose levels are not bad, 7-ish, 6-ish, but it's above that level of a non-diabetic. You'd probably expect that. But now look at this. That's the insulin level in the blood throughout the night. So I think that's Lantus, or a long-acting insulin, so it's gradually wearing off in amount. But if you can see, it isn't really having a huge effect on the glucose, and it's very high level. So this person, over 12 years of diabetes, has got hyperinsulinemia, and they're relatively well controlled. The only thing that might be interesting to you is this here is leptin levels. Now leptin tries to stop you eating, doesn't it? So leptin's trying to help you to survive by trying to tell you not to have your porridge in the morning, because your insulin levels are very high. And also your thyroid levels are very high as well, or relatively high in comparison. Sorry, thyroid levels here. So type 1 diabetes ends up as a metabolic disease over and above a hormone replacement therapy, which is a bit of a disaster, really, isn't it? And this is a paper, you don't need to worry too much about this, but essentially they took some people with no diabetes at all and injected them with glucose or saline and measured the amount of insulin required in order to normalize the sugar level. And they found that after just 40 hours of using insulin, they needed more insulin in those people who they were injecting glucose into. So after just 40 hours of high sugar levels, there was more insulin required, and that was an insulin-resistant state. So what we're doing is causing double diabetes, which is, some people have probably heard of double diabetes, and it's iatrogenic. It's induced by physicians and clinicians, and it's caused by the treatment for type 1 diabetes. And there's one way around this, and that is actually to reduce the metabolic load on the body. And the way you're going to do that is to cut down the amount of insulin the body needs. If you have a metabolic syndrome, of course, you'll be eating less carbohydrates, so you'll need less insulin to handle those carbohydrates. If you have type 1 diabetes, you'll be injecting less insulin because you're going to be eating fewer carbohydrates. And over time, and it does take time, you will eventually end up without insulin resistance, but it can take a long, long time. It can take 18 months or so on a very, very low carbohydrate diet in the ketogenic range, which is just pure fat burning down to about 30 grams a day. So type 1 diabetes ends up as type 2 diabetes, and it can be managed very easily with a low carbohydrate diet. So if you go onto diabetes.co.uk, if your clinicians and register your interest in the type 1 program, you'll be able to help your patients out in the longer term, and they'll do very, very well. And a lot of them will end up in the normal range of glucose control rather than the fairly average 48 to 56, which we're getting in most people at the moment. That's it. Thank you.
Thank you, Ian. That's brilliant. And it's great to have Ian along because, one, he is the most knowledgeable person I've ever met around type 1 diabetes, and I've learned a huge amount off him. And two, in our healthcare system, we do blur type 1 and type 2 diabetes quite often. And I'm not aware ever of, when we've been talking about type 1 diabetes, of a focus of the importance of metabolic health in type 1. The way we've been treating it is just creating this absolute inexcusable disaster. But we keep our prescribing of insulin up.
Thank you very much to Campbell and to Vicky for inviting me. I'm a gastroenterologist just down the road, and I'm going to talk about fatty liver. So for those of you that aren't used to looking at ultrasounds, this is the ultrasound of a liver, which has a lot of fat in it, hence the title of the talk. So we're going to talk just a little bit around non-alcoholic fatty liver disease, how it fits into today, and how it's one aspect of one of the gastroenterological problems that I deal with as a result of the issues that we currently have with the size and shape of our population. But I do have a little bonus at the end, which I'm going to share with you as well. So, fatty liver, what is it? So you already know from the other speakers that fatty liver is part of the metabolic syndrome. It often is a bit of a Cinderella one because obviously nothing's very sexy about the liver. People try not to think about their liver. And in fact, there are two common causes of fatty liver, one of which we'd all rather not think about if we can, which is alcoholic liver disease. Now, to make the differentiation between alcoholic and non-alcoholic liver disease, we tend to say in Taunton that if you're drinking more than 25 units a week, then that makes you much more prone to the fat being related to alcoholic liver disease rather than non-alcoholic liver disease. Now, 25 units, to put that in context, is 5 half bottles of wine with 2 alcohol-free nights. And you think about the population and how much they drink, that's quite a lot of people. So while we have a big problem with this, we also have a little problem with this. So concentrating on the non-alcoholic fatty liver, it tends to be more men, but women have a higher risk of fibrosis. It tends to be those who are diabetic, obese, increased waist circumference, increased insulin resistance, goes up with age, high fructose intake, high blood pressure. So it's very much the same bunch of patients that we're already talking about. The thing about fatty liver is it doesn't have very many symptoms. People might feel a bit tired, but lots of people feel tired for a whole variety of reasons in our population. Occasionally they might get right upper quadrant discomfort, which might be what led them to the ultrasound, which showed the bright liver in the first place. So why is the incidence of fatty liver rising? And there's no doubt that it is. I think things probably started to go wrong in about 1980. So what else happened in 1980? So there was assassination of John Lennon. Nothing to do with that, clearly. Invention of Post-it notes. But there was also the release of these guidelines in America, Nutrition and Your Health. And I tried to cut and paste them from the internet. I think the biggest problem is that this was the point where guidelines started to demonize fat, saturated fat and cholesterol. So it's from these guidelines that we started to get some of our advice that we're all following today. And also the advice to eat foods with adequate starch and fibre. So these things started to be produced. These same guidelines, to be fair, do say avoid sugars, but actually you're clearly having sugars here, but not realising it. So this is probably the start of when the problem started to occur. And we all know when we look at population data that 1980 was about when obesity really started to take off. I've talked a little bit about fructose already. It's a problem with non-alcoholic fatty liver disease. And the reason it's a problem is because we're just starting to eat an awful lot more of it. So in naturally occurring fruit and vegetables, it's probably 5 to 10% by weight in things like apples, probably a bit less in blueberries. But there's very little in milk, meat, veg. In the early 1900s, average Americans ate just 15 grams of fructose a day. It's now closer to 60 or 70. And just to show you how diet changes, fructose is 50% by weight of dried fruits. So where fructose comes from sucrose, which is broken down as a molecule of glucose and a molecule of fructose, but there's also a lot of it in high fructose corn syrup, which is something you'll see if you look at packets. There's an awful lot of this around because it's a very easy way of adding sweetness to things, and that's 55% fructose. So a lot of drinks will contain this. Coca-Cola started adding it in 1980 instead of sucrose, and it's in a lot of highly processed foods. Glucose is regulated so that when energy levels are high in the body, that limits hepatic uptake of dietary glucose, which essentially acts as a brake. However, fructose doesn't have such a regulatory mechanism. It's independent of energy status. So no matter how much fructose and what the energy level is in your bloodstream and in your body, there is nothing that regulates its uptake. So actually that increases lipogenesis, which makes fatty molecules, which then turn into fatty liver disease. And this is a little bit about why we think it's important. So that's a normal looking liver. We know a third of the population, so about 30 to 40%, will have a fatty liver. So this is a non-alcoholic fatty liver disease. It's highly associated with these conditions, so dyslipidemia, insulin resistance, obesity, metabolic syndrome, type 2, all the things we've talked about. So fatty liver is the thing we pick up in ultrasound scans, where the liver looks bright. Now we know that 5 to 10% of these people will go on and get NASH, and this is where it starts to get worrying. So this is non-alcoholic steatohepatitis, which is the effect of this condition causing an upset and inflammation, as has been talked about by one of the previous speakers. So that's associated with a whole heap of metabolic problems, including oxidative stress, which creates free radicals, apoptosis is breakdown of cells, increase in the pro-inflammatory cytokines, which Peter talked about, and they cause damage to the liver to make this non-alcoholic steatohepatitis. We know a percentage of these patients will go further and develop a condition called cirrhosis, which is end-stage damage to the liver disease. And we know that about 3 to 26%, depending on which study, of this 5 to 10% will get cirrhosis. So we really need to stop this here, and preferably we need to stop it here. We know that this is important because NASH, so that the third liver along, progressing to cirrhosis, there's a 10-year mortality associated. The 10-year mortality is 20%. 45% of them will decompensate their livers, which for those of you who aren't medical, that means they'll turn yellow, they'll develop edema in their legs, they're at risk of bleeding disorders, and essentially are pretty sick. 2.6 per year will get hepatocellular carcinoma, there's the increased cardiovascular risk, and it's also the second highest indication for liver transplant. So how do we actually manage to pick up the ones that we need to pick up at an early stage and do something about it? So it doesn't always depend on things like age, gender, body mass index particularly, and percentage body fat. So of these two, one is a toffee, which is thin on the outside and fat on the inside, which is this one on the left, and one is a FOTI, so fat on the outside, but thin on the inside. So this is the much riskier profile because you've got fat in your liver here, you've got visceral fat around your internal organs, and this is the one that leads to the metabolic syndrome and insulin resistance. So we diagnose it on the basis of ultrasound, we exclude with other blood tests. We know that liver blood tests can be normal in a high percentage of patients that still have non-alcoholic fatty liver disease, and the liver blood tests tend to normalize as fibrosis gets worse. So as fibrous tissue starts to develop in the liver, we know that the blood tests don't correlate with the severity, which is very worrying. The clues are those who are centrally obese and diabetic. And we know that there are certain changes within liver biopsy, but because liver biopsies are risky with a 1 in 10,000 mortality and a 1 in 1,000 risk of complications, we try and avoid them. So we try and think about alternative tests. So we can pick up that group, just going back a couple of slides, who are here, and try and prevent this happening by putting our intervention in. For those who are GPs here, you already have access to this, which is the non-alcoholic fatty liver disease fibrosis score. So you plug in things such as age, body mass index, whether they're diabetic, a couple of blood tests, and that calculates a score. And a score of a certain level or above puts them at increased risk of fibrosis, so they're the group to concentrate on. Similarly, we've got a couple of other things coming. So there's more specialist liver blood tests, which you will be able to order, and we've also got a FibroScan, which is quite a nice thing to do. It works well when patients aren't too obese, and what happens is the patient has an ultrasound scan with our specialist nurses, and we have a machine that literally says ping as it's doing the reading, which again, nice for patient involvement. And what that does is to give us a number, which again gives the likelihood that the liver has progressed beyond a certain stage. So for those people, we need to identify patients, we need to risk stratify them. Are they those low-risk non-alcoholic fatty liver diseases of the second liver, or have they progressed to liver 3 or liver 4? Clearly, we need to know about liver 3 and liver 4, but liver 2 needs an awful lot of intervention. So those interventions are here. We've talked about these already. So lifestyle modification, we need to target the metabolic syndrome. Other people have covered that far more effectively than I could. There is some liver-directed pharmacotherapy. So this is chucking jugs at it, which again, is never great really. If you can do it with lifestyle, it's far better. And obviously we need to screen for the complications of cirrhosis, which I've not really concentrated on in this talk. This is a probably now fairly politically incorrect poster from 1980, which kind of says everything we knew about managing these sorts of patients. But again, typical size and shape of one of our patients. And this is NHS Choices, which to be honest, isn't an awful lot more detailed than this poster. I think we can be a lot more specific now, can't we? So diet, we recommend a low-carb diet. We often use the Mediterranean diet because of the literature, but again, essentially you want a low-carb diet full of natural food, high in monounsaturates. You want to avoid sugars, particularly fructose for the reasons we've talked about, and certainly sweetened drinks. The advice is to lose 10% of weight and to maintain that loss, which improves liver histology. I've put brackets around the advice about considering a diet of 600 kilocalories or less, because there is evidence about that, but it's very hard to get patients to calorie count, and I think we often lose their motivation then. It's much easier to talk about real food, avoiding packets, those sorts of things. And there is some evidence around supplementing with fish oils, but then we could just ask them to eat more oily fish, which might be a better thing all round. Exercise, the specific advice that I tend to give, reducing sedentary time and increasing activity reduces steatosis, which is fat deposition in the liver. Aerobic activity is great because it improves insulin sensitivity and skeletal muscle. We give the standard advice of 30 minutes of moderate exercise 5 times a week because that does improve liver blood tests and also reduces fat in the liver. But actually, you can make your exercise aerobic, resistance, or high intensity because they all improve liver fat because exercise is just great for the liver. We always say aim for 10,000 steps a day because people often like having something they can measure, and things such as pedometers and Fitbits and so on are so easily readily available now. It's quite nice. You can engage with your patient, make it a game, make them increase their numbers. This was an interesting piece of research. We're starting now to study low carbohydrate diet and the liver, and this is a paper that was published earlier this year. So what this showed was there's been a lot of work around reducing calories. Is it the reducing calories that makes a difference to fat in the liver, or is it the low carbohydrate diet? But this study has nicely answered that for a number of obese patients in that it used a low carbohydrate diet where the carbohydrates were less than 10% of the energy consumed, but made it isocaloric. So I think we can answer that question now. And what this particular research has shown is there's a decrease in hepatic lipid formation with downregulation of fatty acid synthesis, It modulates gut bacteria, which is what microbiota are. So we've all got billions of bacteria in our colon, which produce a whole variety of things. Some of them are good, some of them are bad. What this particular low carbohydrate diet does is it increases folate production, that being folic acid, and we know that that's very good to reduce this oxidative stress we talked about causing further damage in the liver. It increases the cytokines that Peter talked about reduces cytokines at 14 days. So we know that, again, that reduces progression towards more serious liver disease. And all in all, it starts to reverse some of the things which we talked about, making worse in terms of livers 3 and 4. So if we can cut out a lot of the things that are happening here, we should be able to prevent this happening, avoid patients getting as far as cirrhosis with the cancer risk and the serious liver health risks that are associated with that. I'm not going to say too much about this slide, but for anyone who's interested, there is some work around drugs and also bariatric surgery. But again, if you can do it with lifestyle and diet, then clearly that's a better way forward. But again, I'm happy to go through those with anybody if they wish. Just to give me an extra 2 minutes to talk about this. So another condition I manage all the time is reflux. Now, reflux is acid in the esophagus, and it's something we see very commonly in gastroenterology. It's pretty expensive. There's an awful lot of drug spend on acid-reducing drugs. Occurs in 20 to 30% of the population. We know that a number fail to respond to drugs. We know that a number fail to respond at all. A number have incomplete resolution of their symptoms. We know there are risks associated here with ongoing inflammation in the gullet. So you can develop narrowing, you can develop a change in the lining of the gullet, which puts you at risk of adenocarcinoma. And we know that that risk has increased over the last 3 decades. We know that the risk of reflux, I'm sure you, particularly the health coaches, will have seen this. The more obese someone is, the more they'll complain about things like reflux, and certainly the GPs will. We know that excess fat will increase the amount of acidity in your gullet and increase the number of reflux episodes. And we know it's 3 times higher in obese men and 4 times higher in obese women. I first came to this because we did some research around reducing irritable bowel syndrome in patients, and part of our intervention was that they would see a dietitian who would put them on a low FODMAP diet. What this does, this is a paper that we published, and a surprise finding was that as well as patients doing really well in terms of reducing their abdominal pain and their bloating and their bowel frequency, is they all started to get much better in terms of heartburn, nausea, and things we traditionally associate with reflux. And that was a surprise to us. But actually it fits with research that's come out more recently. So this was a study in America looking at women, and we know from this study, which was a dietary intervention study, putting these women onto a low carbohydrate diet, we know that simple carbohydrate intake, particularly sucrose, will predict the likelihood of reflux, because we know that what sugars are doing is they're reducing the pressure in the gullet, which is a little valve that stops acid coming up, and also causing that valve to relax. What sugar also does is causes that valve to relax. We know it increases sugar increases acid production in the stomach. We know that just decreasing calories doesn't make any massive difference, but we know that 6 days after starting this low carbohydrate diet, there was a 44% reduction in symptoms, and we know that all of the women actually decreased them and discontinued their medication 10 weeks after they'd started this diet, and that lasted until the end of the diet. We don't have any longer term data following up these patients, but we can assume that if their symptoms are that much better, then they're going to stay on this diet. So I just wanted to share that at the end, just to explain. And if there's anything anybody wants me to go through afterwards, just come and find me.
Brilliant, thank you, Emma. Just from, again, post-reflection GP work, the number of patients with raised liver functions, particularly one we measure in Somerset ALT, is just enormous, and we've generally, I know I have ignored it, because what do you do about it, and there's no drug for it. So that, reflecting on that, and then also reflecting on type 2 diabetic patients. So taken through a reversal process, they came across this idea that all their acid symptoms went away. And just maybe reflect of this typical patient, overweight, type 2 diabetes, on an anti-acid tablet, and you just do some relatively simple lifestyle change, and this person moves back to being a person that doesn't need all those drugs. Body's working the way it should do without symptoms. Really simple stuff.
Hello, everybody. My name's Emily. As Campbell said, I'm a health coach, also a healthcare assistant and a receptionist at Queen Campbell Medical Centre. So I qualified as an OT back in 2002, before I worked in various hospitals and community settings up until I had my children in 2007 and 2008. At that point, I was 8 stone heavier than I am today. So I've kind of been through my own, I have been through my own personal journey along the way. Decided I needed a career change, so took up a role as a healthcare assistant at Queen Campbell Medical Centre, and my role has continued from there in reception as a health coach. Huge passion for health and fitness now. And last year I was approached by one of our GPs to try and tackle our pre-diabetics, our 42 to 48 people that need to do something about it. So anyone with an HbA1c of 42 to 48 previously were deemed normal. The person would phone up and receptionist would say, yeah, that's normal, that's fine, you carry on what you're doing, think no more of it. But actually, those are the people that can make a huge difference. Alarm bells at this point should be ringing. So anybody in this range, or a GP or a practice nurse who feels that would benefit some coaching from me, are asked to come and see me. So Postman Pat helps me along the way, and we send out anybody who's sent a task to me a letter inviting them in for a 30-minute consultation. We have had an amazing response rate of about 65% of people just coming in from that letter, which to me is pretty impressive. And a key to that is the wording. There's a lot to read there, so if you want copies of this, what we've been saying to patients, you feel free, we're very welcome. But it's really saying to people, you can do something about this. This is scary, but we can help you along the way. We try and motivate people for change and get them to turn it around. So they come and meet with me for half an hour, and I explain in very simple Emily terms, which are always very simple, what the HbA1c actually means. It's all very well banding around these numbers and these letters, but these poor patients, they often sit there and think, what are they on about? I don't know. So I explain to them what it means, and if they understand a little bit of the science behind it, hopefully they will then be more proactive and motivated to make changes because they understand why they are doing it. I use Peter's, the pictures of all the sugar teaspoons. I haven't put a slide up. I use that during the consultation, and that is really powerful to show people. I heard you all go, 24 teaspoons, that's amazing. And it is. You can show people that they can make a difference with a few tweaks and changes, it's very important. Tesco's, Sainsbury's, all the supermarkets have great nutritional values. You can say to them, give me a food item, and you can type it in and it will show you the carbohydrates per 100 grams. And that's a really useful tool that I use, as well as food labels. So they go away with very, very little information from their consultation with me. In fact, it's pretty much this piece of paper from the Public Health Calibration and their results. And what the aim of this is to empower them to show that they are the ones in control. We give them the tools, we show them where they can go and look for that information, but it's up to them to make the change. I can't come and make every meal for them and tell them what to eat. So it's encouraging people to take their own responsibility. So, Public Health Calibration UK, if you haven't looked at their website, don't know anything about it, go. It's amazing, it's fantastic, and it's a great source to help your patients. We look at what the patient's been eating, what they could be doing differently. I do explain to them about carbohydrates, but then we go through their daily menu, what they would be eating, and attempt to make some alterations between us. It's a conversation. It's not me sitting dictating to them what I think they should be doing. This is up to them. This is their goals. This is their life. So we help them set goals, making them realistic, achievable, all the rest of the SMART goals, but it needs to come from them. It might be really important to me, and I'm thinking, you should be changing that, you shouldn't be doing that, but actually, no, they want to do something different. One example, I had a lady who came to see me because she was in the pre-diabetic range. She went away and she gained 7 kilograms, but she stopped smoking 3 months later when she came back to see me, and that was brilliant because her goal at that point was not to tackle her diabetes or pre-diabetes, it was to tackle her smoking. And then the next goal from there was going to be, or is, the HbA1c. So the patient then leaves me, full of excitement, motivation and knowledge, and they go away for 3 months, but they are invited at any point to make contact with me during office hours. They return for a review 3 months later, where we repeat the HbA1c, height, weight, blood pressure, cholesterol, etc. And then we can reflect, review and plan and see where we go from there. We have had some amazing results. And to be fair, this is the average, it doesn't do it justice, but with our probably 150, 160 patients, the average reduction is 1.5. And this is just from half an hour with me. And an average of a 2.4 kilogram weight loss. So bearing in mind, you've got some people who've gone away and ignored everything I've said. Some people have done a brilliant 10 kilogram plus weight losses and massive reductions from high pre-diabetics right into the normal zone, as we've all been sharing some of our great stories today. So to me, the magic, why does it work? Encouraging moderation. Don't let people think they can go and change the world. It's just making small tweaks and changes, things that we can make a difference. How we make up our plates. It's not going and changing everything that we're eating. It's explaining to people that a few different ways, less pasta, no pasta, more meat, more vegetables, it can make a difference. Again, a lot of people have said it this afternoon, diets don't work. It's got to sell it as a lifestyle. This is your lifestyle journey. It's not a diet. They just don't work. Having a very positive but interactive approach, I do think that makes a massive difference to people. We've had some great people bouncing back, as other people have said today. So there we go. Over back to you guys.
Good afternoon, everyone. So my name's Vicky. My background is working on NHS projects in Somerset, which focus on health and well-being at both of people and also at the community level. And that's involved working in GP practices, offering one-to-one support to patients in a health coaching type role, when I was working with Health Connections Mendip, and also group work, sort of self-management courses for people with long-term health conditions, and also doing a lot of work in the community revolving supporting people to increase their knowledge, skills and confidence around healthy lifestyles. I'm also a volunteer health walk leader at my local GP practice, and I organise free creating health events, a little bit similar to what we've tried to do today. And I'm also a recent convert to the park running phenomena, which I'll talk to you about in a minute. So what I'm hoping to do today is to share with you some of the work and projects I've been involved in, which I think demonstrate ways that support people towards better metabolic health, even if it doesn't seem like it's a direct link. So what I've noticed over the years while I've been working in primary care, that there's been a real shift in focus from the moving away from that traditional biomedical approach to managing people's health and thinking about things in a much more rounded view, thinking of us as people set in the wider context of our lives, and one that acknowledges the wider determinants of health as well, which drive health inequality. And I noticed that while providing one-to-one support to patients, it was really obvious to me that their beliefs and wider life events affected how much they were able to address their immediate health concerns. And I think this has been touched on a little bit already by Emily and Peter. So it's well known that health information alone is ineffective, and behaviour change is a difficult process. It requires sustained motivation and support, but I think that's where the key is. If you can find out what motivates the person that you're speaking to and what gives their life meaning, you've kind of got a hook whereby you can work on solutions together and sort of formulate a plan as to how people are going to move forward and address some of their health concerns. And a tool which has really helped me to do that is the Human 5 framework, which some of you may have seen. It's a tool that Campbell developed and has been refining over the last few years. And I found it to be a really useful tool when I'm working with patients, both in a one-to-one setting and also in a group setting. So for those of you who haven't seen this is just, it's a tool that you can use to facilitate the conversation. And whether you're a health coach, whether it's in the 8-minute GP consultation, whether you're a consultant working with the patient, if you're trying to find a way to guide that conversation and to enable the patient to talk more openly about different aspects of their lives and what may be going wrong with them, this is a really good plan to help you to do that. So it facilitates discussions around the things that impact on people's lives and their health, and it breaks aspects of their lives down into broad topics. So the topics here you can see, I think just about, we've got movement, mind, nutrition, body, and world. And what this does is it helps enable patients to identify and acknowledge their problems and concerns, but it also asks a fundamental question, and that is, what matters to me? And once you've kind of found out what the answer is to that question, working with that patient in these person-centered approaches that we are all using now, you can start thinking about solutions and actions to work towards problem solving. And this factor, actually, this bit about what matters to me, and this has clearly reached national importance now because it's a part of the National Health Service campaign, and every year now they have a What Matters to You Day, and this is where they're trying to encourage people to have better conversations with their patients and really try and improve relations, build better understanding between each other so you can work towards a shared purpose. I've also used this tool when I've been working doing self-management courses in the community, and I found that it's the community setting when you can move the patients out of that clinical environment and back into the community where we live that I've seen the most powerful behaviour change. So what I'm just going to cover with you over the next few minutes now is have a chat to you about the Creating Health Roadshow events, health walks, park run, men's sheds, and then just touch a little bit on politics as well, which we haven't really talked about today. So the Creating Health Roadshows, we've been running these for over a year now in different towns in Mendip, and the aim of the roadshows is about bringing the metabolic health message to a wider audience. The aim is to inform and inspire people about achieving good metabolic health and to give people the confidence to overcome challenges they may face with type 2 diabetes or achieving a healthy weight. It's very much a community event in every sense of the word. And you can see what we're trying to do is make sure there's lots of information for people by having up-to-date nutritional information from a clinician. We have a testimonial from a patient, similar in the way that Steve today has shared his story. That is very powerful for people to hear other people's testimonials. And by sharing good stories, it can be a real motivator. We have plenty of time to answer questions. And then we try and inspire people by offering them a tasty, colourful and healthy and easy to replicate buffet, which you'll get to try a little bit later on this afternoon. And we also give people the opportunity to try some gentle exercise. So we have a guy who lives locally, gives a free Tai Chi session for people to get involved with. And we really see this as an enabling opportunity. So we provide information from local community organisations and services, exactly exactly what we've tried to do today. So I don't know if you've noticed, but we've got Joe here from Zing, we've got Matt here from Spark, and we've got Katrina here as well from Engage, and we've also got Phil up the back from Somerset Local Foods. And what we do is we invite members of the community groups along so that people can chat to them and find out the support that's available for them in the community to enable them to change their behaviour. And we also raffle off some cooking equipment as well, and give out some recipe books. So I think with the Creating Health events, there's no doubt about it that the talk is the draw. People come because they want to hear Campbell speak about the topic, but it's the other stuff that goes on around it that really puts in, makes it an extra special thing, and that's why we have such good feedback about these talks. So, yeah, so here's the gang. In fact, most of the people who are in that picture are here today. So thank you, everyone, for the support you give us at these events. We couldn't do them without you. So I'm just going to come and have a chat to you about my experience as a walk leader. So there's over 1,800 free, short and medium walks that leave places in England every week. They're led by volunteers. We're lucky that in Somerset, many of them leave from local GP practices. And I think these are a gift on your doorstep. This is something that is just provided for you in your community. And if you're not already leading health walks or organising health walks from your GP practice, I strongly recommend that you looking to see how you can facilitate that happening. So I asked the walkers who come on my Friday walk, why do they join their local health walk? And there's some, reasons that we would expect, such as feeling isolated and not fit, wanting to get fitter, wanting to meet other people, managing a long-term health condition, and getting lots of benefits from that. But there's one of our team actually emailed me his answers because he felt it was really important to share with us why he joined the Health Walk scheme. And although it's not specifically about pre-diabetes or diabetes, I think what this quote illustrates is the many things that spin off when people decide to do something positive for their health. And so I'm just going to read this quote out to you. So as you can see, the benefits have been so much more than I was expecting. It's given me the confidence to become a health walk leader myself, and I've gone on to be heavily involved with the carnival. In turn, it has given me the experience and knowledge that I can take into future life situations and a working environment. So I think of health walks as a catalyst for change. And just from our one walk that I started nearly 4 years ago, we have a large number who walk every Friday. We go up the Tor every 3 months, and for some people, they've never been up the Tor in Glastonbury, and they've lived there for 20 years. So it really can empower people to try things that they maybe wouldn't have tried before. We've even got a spin-off group who walk on a Wednesday together and do things like go to the pub and do really long walks as well. And it's from the team and the friends that I've made through the health walk that the Creating Health roadshows have really been supported, and those people have joined us today to help us put on these types of events. So I just want to talk to you a little bit about Park Run as well. Have you all heard of Park Run? Has anybody not heard of Park Run? Does anybody go to Park Run? Okay, that's a few. Good. If you've never been to Park Run, I strongly recommend on a Saturday morning you get up and go and have a look and see what all the fuss is about, because this is another phenomena that is just sweeping the country at the moment, and in fact many countries across the world. This is a free event at 9 o'clock on a Saturday morning where people can go along and walk, run or jog for 5 miles. It's hugely supported by volunteers, and it's transformational. I think my experience of Park Run, really, I'd have to think about Carl here. So Carl's my partner, and we've never done any formal exercise together other than walking a lot in the 18 years we've been together. Park Run is now become a massive part of Carl's life. So if any of you want to know about what motivates people to Park Run, have a chat to Carl in the break, and he'll be able to share to you just why it's such an amazing thing to get involved in. And you don't have to be fit to join in. You don't have to be a certain size to join in. And some people, health walks aren't for them, but Park Run is going to tick the box. So if you're looking at ways of signposting your patients to that wider community support, just give them a nudge and let them know about their nearest Park Run. men's sheds. So the reason I've put men's sheds on here is it may not seem like a really direct link, but there's plenty of evidence showing that loneliness and isolation can have a devastating effect on people's health and maybe exacerbate long-term health conditions or even continue towards them. And that is the same for type 2 diabetes as well. So there is some evidence to show that people who are lonely and isolated are more likely to develop type 2 diabetes. And the fantastic thing about men's sheds is it's a community space for men to come together over a shared topic, a shared vision, and it's an opportunity to have a chat, overcome some of that loneliness and isolation they may be feeling, and generally just kind of re-engage with the community. You don't have to be lonely and isolated to join a men's shed, and plenty of people never reach that lonely and isolated stage because they've managed to keep those social interactions going their whole lives. But I helped to set up a men's shed in Street about a year ago, and it took over 6 months for the guys to find a venue and another 6 months to actually realise the vision, get the renovations done and start using it as a shed. But for that whole year, they were meeting on a regular basis. They were plotting and scheming, making plans, drinking tea and improving their health and well-being. So it's another really great community initiative out there that you can signpost people to, because sometimes directly asking people about their diabetes and coming at it from a strong clinical view may not always bring about the result that you want. And just getting people to have the opportunity to make interactions with other people and live as human beings, our health naturally improves, and that could be the same for metabolic syndrome and type 2 diabetes as well. Now, I think it would be remiss not to just touch ever so slightly on some of the wider issues about people's health and what contributes to poor health in this country. So we've had a look at what things that people can do as an individual and what they can do in their community, but let's not forget that there's a role here for policies and regulatory frameworks too. It should be a lot easier to make healthy food choices. It shouldn't be so hard to eat well and to have an active life and to be healthy and happy. And as Peter touched on, talking about ultra-processed foods, currently ultra-processed and fast foods are cheap, they're easily available, and they're formulated to be tasty, not healthy. There's conflicting dietary advice. In some neighbourhoods, healthier food is not available and it's not affordable. There's a perception that healthier foods are more expensive, and not all neighbourhoods support being active outside. So the reason I just want to touch on this is that this is a society problem, and it needs a society to solve the problems. So we as individuals and citizens have a role to play in agitating for better policies, better availability of food, and better structures to reduce health inequalities. So what can we take away from this today? So I think it's important to think what's important to the person you are working with, what matters to them. Could you organise a community health event for your town? And if you'd like help with that, just come and have a chat to us, and we'll let you know how straightforward it is to organise a good community event where you can really spread the message to lots of people. Reach out to your local community initiatives. Find out about your Walking for Health schemes. Get them at your GP practice if you're not already running them there. Become a health walk leader. Find out about your park run, check it out, signpost your patients to it, and see if there's a men's shed going on in your area now. And finally, I just want to say, campaign for better food for all. And that's it. Thank you.
As I listen to that, not only does it bring in all these other extremely important parts of how we create health for individuals and populations, but also really reminds me that we never have to sit around waiting for permission to do anything. If we can see a way we can improve the world, we can just go and get on with it. We don't need to wait for a strategy to written from above. Just go and do. I'm going to sort of talk through actually how, or start to get us thinking about what we can truly do. This pandemic, this epidemic is we can sort it. I have absolutely no doubt in my mind that if we put our efforts together, we could make enormous changes within 1 year. And I think if we wish to, within 5 years, all of this stuff we've been talking about today, we'll be well on our way to sorting out. people's health would be better, and certainly the health and social care system would be salvageable. And just some reflections, I guess, before we start going through this on what I'm seeing in the world at the moment, because we all see our own things, we all see our own realities depending on what we're exposed to. Some of and just the gravitas of what's going on around this stuff. So through my role with diabetes.co.uk, as I mentioned, we're rolling out a type 2 diabetes reversal program and the type 1 program coming soon. That's partnered with two of the world's largest reinsurers. So insurance companies that insure insurance companies. The reason they're interested is they've got life insurance and critical illness policies. And if those policies start paying out on a massive scale, the reinsurers have got to pay out to the insurance companies. They've done their sums and they've looked at this and thought they're going to be bankrupt if they don't do something. So for the first time ever, there's probably a corporate interest in actually improving people's health. If they're interested, I think there's a bit of a duty that we should do something on a local level too, and also maybe feel inspired that actually I think the southwest of England is a bit of the beacon of the country, and the country is the beacon of the world around all this. So we could really be leading the local charge. So yeah, I just want to start us thinking about actually this is possible. This concern we have is, why is everybody getting sicker? Why is everybody getting type 2 diabetes? Why is everybody getting fatty liver disease? Why are so many people getting Alzheimer's disease? It can seem quite overwhelming, and with that, you lose belief in that you can do something. As I think we've heard through today, we've got massive belief that what we do can make a difference. You need that belief because you've got to put some effort in and put some work in. But with that belief, we've then got to start putting things into action and turning the scale of this up. Not just for me, when I was just doing GP one-to-one with a patient, I thought that's good. But actually, how for that same unit of energy could I create a 10-to-1 or 100-to-1 or 1,000-to-1 return for people? So yeah, knowing what is possible. So as I've just covered, what we've talked about today, what each talk has spoken about, what many people have experienced for themselves or know people about, we know that improving people's health is possible. We know that all these things, or many of these things, are preventable, and we also know that even once it happened, they can be massively improved and in some cases, inverted commas, reversed. So one of the key things, and it reflects on, I guess, on today, and it reflects on these creating health events, it reflects on where the health and social care system's trying to go. We are no longer in a system where doctor knows best, passive disease walks into the room, disease gets diagnosed, gets a drug, walks back out again. We're in a system where actually the stuff that we are seeing in the health and social care system, the stuff that people are struggling with, is related to how we live our lives. The fundamental important thing with that is people need to know that. People need educated, people need the knowledge, we need to advertise this, we need to put as much information out there as possible with a really positive spin of hope that people know if they go on this journey, if they put the time in, they can truly make a difference to their health. This, empower ourselves with knowledge, which is what today is partly about. Every single person in this room and every single person working in the health and social care system in Somerset, the southwest, the country, the world, will be interested in improving the health and well-being of the people they interact with. They'll be interested in improving or using their time to have the greatest effect. The challenge is if our knowledge isn't sufficient, then we may be unwittingly not using our energies in the best possible way. Equally, as we've spoken today, and my own personal journey, 6 years ago, I didn't know any of this. I was going to work, I was being person-centered, I was really trying to empower people and support them, getting terrible results and just thinking this is the way it is. By learning, I've learned a lot. We've all learned a lot today, and we've all shared a lot of knowledge. That can make a massive difference, but this learning never, ever, ever stops. Some of what we've spoken about today, we'll know something a bit different in another 5 or 10 years' time. We should never rest and think, okay, this is exactly what we have to do. We don't stop, I don't think, until every single person who could possibly have their health and well-being improved, even just by 0.5%, that we've done that. Collaboration, thinking about people, technology, organizations. Again, one of the ways I look at the world is there are 7.6 billion people on Earth and growing. The only way you can impact on 7.6 billion people is by trying to collaborate between all of those 7.6 billion people. Often reflect the similarity, or sometimes the world can be quite competitive, can't there? There's egos at play, and kind of people are most interested in the thing that they do. And often reflect that the amount of poor health out there, if somebody's kind of wants to be driving forward with their thing to fix it, they don't need to worry. We're not at a jumble sale. We don't need to have our arms out with getting that the last cardigan before somebody else does. If we fix this metabolic health problem, there'll be another thing we can put our efforts into. It's an endless thing. So I think the more we can collaborate, and the more we can find shared goals, the more we can focus on better communications, better relationships, helping the system adapt, but which can be sluggish due to its nature, but just getting on and doing things. My kind of some of my ventures now, seeing the potential around technology. How do you get to, in Somerset, 500,000 people? China, I think, where they have a clear problem with a massively growing population, a real deficit in healthcare professionals. They're heavily investing in technology because that's the way you can get to lots and lots of people. You combine that with the technology, with empowered people, with health coaching, with community development, with peer support groups, creates an extremely different model to 10-minute appointment with a GP. Supporting the journey, which brilliantly we've spoken a lot about today. Again, from a traditional medical background, we will think of, okay, what's the problem? We need to give this drug. That doesn't take much effort. Have your drug, off you go, job done. And therefore, we haven't necessarily, until the last few years, really been investing in and thinking about how do you support people on their journey. And I love this way of looking at things. So to embark on a behaviour change and certainly change habits, you have to believe that it's possible, and you have to believe that you might get to your end goal. Otherwise, it's extremely hard to change habits, because why would you change a habit if you don't think it's going to work? So there's a real onus on us to support people and have genuine, high integrity belief and instill that in people that it's possible. But it doesn't happen like this, as we all know. This is a journey, and this is a real journey. And I always think that nobody knows this journey better than yourself. And our job really is to support people on that, knowing that there's twists and turns, knowing that there's loops, knowing that we're heading in this sort of direction, but there's no right or wrong. One of my fundamental principles I think I've learned being a GP for the last 15 years is as soon as you instill this idea of right and wrong and judgment, I think, just speaking to patients, the number of people I think have grown up being judged as good or bad, with behaviours being judged as good or bad, which then reflects on whether or not they are good or bad, is astonishing. And equally, we all see the world in different ways. So the challenge that would then create if we're not careful is we judge somebody else's behaviour on our terms. We impart that as a good or bad behaviour, which imparts onto them they are good or bad, and it sends down this horrible, horrible loop. So the alternative is a person knows their journey better than anyone else. We support that journey through empowering them when we need to, and sometimes just through relationships. We know that this is okay, and there's no such thing as failure. We just continually learn, continually improve, and find out what's helpful and what's unhelpful. And it creates the successes I think that we've heard about today. Finally, taking unrelenting action. Again, actually it sums it up in this phrase: the difference between who you are and who you want to be is what you do. I think the difference between where we are and where we want to be is what we do. The fundamental thing I think hopefully from today and some discussions we can have a bit later is actually if we just get up and do what we believe in, find out what we're passionate about, and find the thing that gets us up every morning, want to walk out the front door with some energy. If it's linked to this, or if it's linked to anything else, you will see results, because that natural doing will be driven from your internal motivation, like our patients when they need to change, when they need to find the motivation to change behaviours, linking it into what matters to them.